Okay, let's jump in. Today we're doing a deep dive into something that feels like one of those massive, almost unsolvable global challenges, preventable blindness. And when you first look at the numbers, I mean, the scale is just staggering. You've got somewhere between 37 and 45 million people who are blind worldwide.
It is a huge number. But what's even more telling is where this problem is concentrated. The reality is that over 90% of visually impaired people live in low-income countries.
Right.
And if you drill down even further, almost a third of the entire world's blind population is in South Asia.
So the burden falls on the places that are, least equipped to handle it. But here's the statistic that really frames this whole conversation, the thing that makes it solvable. 75% of all blindness is avoidable.
Exactly. It's either preventable or, in most cases, it's curable, usually with a pretty straightforward cataract surgery.
Which means millions of people could have their sight back if, and it's a big if, you can bridge that gap between the medical know-how and the huge populations that need it.
And it's right there, in that gap, that our story begins.
This is the story of the Aravind Eye Care System, or AECS. It was founded way back in 1976 in Madurai, India, by a man named Dr. Govindappa Venkataswamy. Everyone just call him Dr. V.
And Dr. V's mission was, let's just say it wasn't small. His vision was, and this is a direct quote, to eradicate needless blindness, period.
He started with just an 11-bed hospital. That's it. Funded it with his own family's savings. But the founding principle was absolute from day one.
Right. To provide free treatment to anyone who couldn't afford it. No questions asked, no exceptions.
And this wasn't just, simple charity. Dr. V was driven by this concept of selfless service and something he called divine dissatisfaction.
I love that phrase. It wasn't about building a good hospital. He wanted to start a mass eye care movement.
And he did. Today, Aravind is the largest eye care system on the planet. They do almost 500,000 surgeries every single year.
Incredible numbers.
So that's our mission for this deep dive. Aravind is held up as this perfect example of a social enterprise. We want to get into the nuts and bolts of how they do it, how they achieved world-class quality at this unbelievable scale, all while staying completely self-funded.
It's a masterclass in combining efficiency with just radical compassion.
It really is. So let's start with the money, because that's the engine for everything. In a world of skyrocketing healthcare costs, how do you give most of your care away for free and not just survive, but actually grow?
It comes down to a really unique model of internal philanthropy. The whole system is built on something called cross-subsidization.
Okay, break that down.
They get to financial sustainability by being ruthlessly efficient, high volume, low cost, and then they pair that with a very clear tiered pricing structure.
Right, the tiered system. This is where the genius is, I think. So you have two main groups of patients, the ones who pay and the ones who get it for free.
Yes, but, and this is the crucial part, the clinical quality, the actual medical procedure is identical for everyone.
So the surgery itself is the same.
Exactly the same. The only difference is in what they call the non-clinical frills. A paying patient might get a private room, maybe air conditioning, better food. A non-paying patient gets a clean bed in a large shared ward.
But when that surgeon walks into the operating room, it doesn't matter who you are.
It makes no difference whatsoever.
And the number of non-paying patients is huge. It's something like 50 to 70% of everyone they treat.
It is, which meant they had to figure out the financing from the get-go. And Dr. V set up this very simple, very powerful rule.
What was that?
The fee for a paying patient was set at a level so that every single paying patient covered the cost for 2 free patients.
So a 1-for-2 ratio.
That's the magic formula. That's the cornerstone of their entire financial model.
But to make that work, your cost per surgery has to be incredibly low. And this is where Dr. V made this famous kind of controversial comparison. He asked if eye care could be McDonaldized.
Yeah, that definitely raised some eyebrows. He wasn't saying surgery is like making a hamburger.
Of course not.
He was asking if the principles of McDonald's standardization, massive volume, optimizing every single step, could be applied to medicine to just crush the costs.
But the big worry there is always quality, right? If you standardize something like surgery, does the quality drop?
It's a valid concern.
Yeah.
But they managed that risk through, well, extreme specialization and process control. They made sure that even a very low fee would generate a surplus, but only because the volume was so immense. They applied economies of scale to everything, especially the surgeon's time.
And the most famous innovation for that is the two-table surgical technique. Can you walk us through how that actually works in the operating room?
It's just a brilliant piece of workflow design. So in a normal OR, a surgeon operates, then waits. The room is clean, the next patient is brought in, prepped. There's a lot of downtime.
Right, idle time for the most expensive person in the room.
Exactly. Aravind just eliminates it. They use what's basically parallel processing.
2 tables.
2 tables. A single surgeon sits on a swivel chair between them. While they are performing the cataract surgery on patient A, a team of assistants is on the other side, at the second table, prepping patient B.
Getting them draped, anesthetized, everything.
Everything. The second the surgeon finishes with patient A, they literally just swivel their chair and start immediately on patient B. There's almost zero wasted time.
And that completely changes the math on throughput. A normal ophthalmologist in India might do, what, a few hundred surgeries a year?
A few hundred, yeah. An Aravind surgeon consistently does 2,000, sometimes more. That kind of volume is what underpins the whole low-cost model.
But a surgeon can only do that if they're not doing anything else. Which brings us to the next big innovation, task shifting.
Yes. This is absolutely critical. For every 1 surgeon, Aravind has 4 to 6 mid-level ophthalmic personnel, the MLOPs.
Tell us about the MLOPs. Who are they?
They're mostly young women, recruited from local villages and then trained internally by Aravind. They handle all the standardized but essential non-surgical tasks.
Like
taking patient histories, doing the pre-op measurements, sterilization, preparing equipment, post-op care, counseling, all the stuff that a highly paid surgeon doesn't need to be doing.
it frees up the surgeon to just do surgery.
Do the one thing only they can do.
Yeah.
And think about the social impact there. You're giving technical skills and employment to young rural women. It connects the medical mission to economic empowerment.
Absolutely. And to make sure quality stays high with this kind of assembly line speed, it all runs on protocols, standard operating protocols or SOPs for literally everything.
Everything. From how you price a procedure to how a patient moves through the hospital, it's all mapped out. And they use technology to manage it, like their own hospital management software, the IHMS.
And they use things like RFID tags to track patients?
Yeah, on the patient charts. So they can see in real time where everyone is. They can spot a bottleneck in the post-op ward and shift staff over there instantly. It's all about real-time optimization.
So the process itself guarantees the quality, not just the individual surgeon's skill.
That's the goal.
Okay, so the hospital itself is this incredible engine of efficiency. But the biggest problem is still out there. How do you get the patient, who's poor, lives in a remote village hundreds of miles away, to that operating table in the first place?
That's the access problem. The vast majority of people who are blind live in these rural areas. They can't afford the bus fare to the city, let alone the lost wages for them and a family member to take a week off work.
So Aravind developed a 2-part strategy to go out and get them. Let's start with strategy 1, the outreach eye camps.
These are basically temporary pop-up clinics. They set them up in remote villages, maybe in a local school or community hall, often working with local partners like the Lions Club.
And they offer free screenings there.
Exactly. The MLOP teams go out, screen hundreds of people. But the real genius is what happens next. If they diagnose someone with cataracts who needs surgery,
How do they solve the travel problem?
they just remove it. They remove every single barrier. They tell the patient the surgery, the food, the accommodation, it's all zero cost. And then they arrange a bus to pick them up for free.
They just bus them in.
They bus to the base hospital, they get the surgery, they recover, and then they're put on a bus and taken right back home.
That is the feeder pipeline. That's the connection between the mission in the villages and the business model in the city.
And the scale is just mind-blowing. In 1 year, 2018-2019, they ran over 2,800 of these camps and screened more than 500,000 people.
Wow. But a camp is a one-time event, right? It's episodic, which led them to strategy 2,
Right,
the permanent vision centers.
right. The VCs, this was an evolution that started around 2004. There's small, permanent clinics in rural towns. Think of them like satellite offices. Each one covers a population of about 50,000 people, and they're open 6 days a week.
So it's continuous care, not just a one-off screening day.
And this is where the task-shifting model gets pushed outside the hospital. The vision centers are staffed entirely by trained MLOPs. There are no doctors on site.
Okay, so how do they handle a complex diagnosis then, without a doctor?
Technology, that's the bridge. The VCs are all connected to the main hospital via telemedicine. An MLOP can take a high-resolution photo of a patient's retina, upload it,
And a specialist in the city can look at it in real time.
and even do a video consultation. So a villager gets expert advice without ever leaving their hometown. It's using frugal, appropriate tech to solve that specialist scarcity problem.
And do they charge for this?
They do charge a tiny nominal fee,
Right.
maybe 20 or 50 rupees, less than $1. It's just enough to give a sense of value and help the center be locally self-sufficient. But of course, if someone can't pay, they're still seen.
The ethos holds. Okay, so we have the efficient hospital and the outreach system to feed it, but both of those things need a constant supply of two things: trained people and affordable materials. Let's talk about that internal engine, starting with the people.
Yeah, Aravind knew early on they couldn't rely on the market. They had to essentially manufacture their own talent. And that's what led to the creation of the Lions Aravind Institute of Community Ophthalmology, or LAO, in 1993.
And LAISU has two jobs, right?
Two main roles, yes. Internally, it's the training academy for all of Aravind's staff. It's where they learn the technical skills. But just as important, it's where they're immersed in that mission-driven culture of SEVA.
And the external role.
Externally, LAIO is the consulting arm. It's how they export the entire Aravind model. They take the template, the workflows, the financing, the quality control, and teach it to other hospitals all over the world.
So they're not just doing it, they're teaching others how to do it.
On a massive scale. By the late 2010s, they'd trained over 8,000 professionals from more than 100 countries. They've mentored hospitals in Kenya, Guatemala, Ethiopia, helping them build their own versions of the Aravind system.
Okay, that's the people part. But the other crucial piece was controlling the cost of supplies, which led them to vertically integrate and create OralLab in 1992. Why was that so necessary?
It all came down to one specific item, the intraocular lens, the IOL, the little plastic lens they implant during cataract surgery.
Oh.
At the time, a high-quality IOL had to be imported, and it cost between $80 and $100. That one cost alone would have completely destroyed the cross-subsidy model. You can't give away surgery for free if the main component costs that much.
So Dr. V just decided, fine, we'll make our own.
Basically, yes. And the impact was nothing short of a revolution. OralLab figured out how to make a world-class IOL and brought the cost down to under $10.
From 100 to under 10.
And at scale, they can now produce them for as little as $2. That single decision meant that every patient, paying or free, got a modern lens implant. It standardized the quality upwards for everybody.
And that's just a profound shift. It ensures the poorest patient gets the same quality of outcome as the wealthiest.
Absolutely. And today, OralLab isn't just supplying Aravind. It exports lenses, sutures, and other ophthalmic products to over 130 countries. They didn't just solve their own problem, they helped lower the cost of eye care globally.
All right, let's pull all these threads together. Let's distill the success factors. They've scaled across India, they have 14 major hospitals, and they funded almost all of that growth themselves just by reinvesting their surplus. How do they keep quality so high when the pace is so fast?
Through obsessive measurement and total transparency. They track every surgeon's complication rates, and those rates are reviewed openly by everyone every single month.
So there's accountability.
Huge accountability. And they stick to these incredibly strict protocols. Their infection rates, for example, are around 0.05%. That's on par with the best hospitals anywhere in the developed world.
Oh, if we boil it all down for the listener, what are the, say, 3 key ingredients to this incredible success story?
Okay, I'd say first, it's the missionary values, that deep-seated commitment to SEVA. It keeps the staff motivated and focused. The goal is always restoring sight. The money is just the tool you use to get there.
Right, not the other way around. Okay, what's second?
Second has to be frugality and efficiency. That's the operational genius. The two-table technique, the task shifting, all the things that drive the cost per surgery down into the basement, which makes the whole financial model possible.
And the third piece?
Process and continuous improvement. They standardize with SOPs. But they're not rigid. They're constantly measuring and adapting. Like when they noticed post-op follow-up rates were really low, they didn't just accept it. They invented post-op follow-up camps and got those rates up to nearly 90%. They never stopped tweaking the system.
It's that complete system that makes it so powerful. And why its influence is so global now, it proves that you don't have to choose between excellence and equity in healthcare.
And you can't forget the final economic impact. When you restore someone's sight, they can go back to work. Some studies estimate a 1,200% economic return on that investment. So Aravind isn't just a health organization, it's an anti-poverty engine.
It really is a proven, sustainable model for creating massive social change.
Which brings us to our final thought, a question for you to really think about. One analysis found that for every single dollar you invest in this kind of eye care, you get about a $36 return in economic productivity. So given those staggering returns, both human and economic, and given that Aravind has laid out a successful, proven template, why does preventable blindness still exist at such a massive scale? What's really stopping this self-sustaining model from being adopted everywhere in the world?
Thank you for listening to Mission Possible, innovating for the world's most marginalized. This podcast is built on the outstanding work of our students, whose curiosity and commitment drive much of the research and storytelling you hear. Each episode is grounded in academic research and shaped through close collaboration with our partners. To learn more about the research and partnerships behind this podcast, feel free to contact us. Thank you for joining.